Hello, good evening, everyone. Thank you for inviting me to speak at this very important meeting amongst very distinguished peers. I'm fairly new to the UAE, so it's an absolute privilege to partake in meetings like this. And this topic is fairly dear to me, having seen about 100 cases over the last few years in the UK. And I have had the good fortune to collaborate and publish on it as well. Some historical perspective is perhaps very useful to understand the evolution of MOGAD. 150 years ago, it was all MS. Until such time that Devick separated out NMO as a distinct entity. Unfortunately, for Devick, in the absence of any specific pathological or immunological marker, it did not stand the test of time. And soon, NMO became a severe form of MS. Though there have been various attempts since to revive NMO, it was Brian Weinshenker's and Dean Wingerchuk's work in 1999, where they used long-term outcomes and statistics to clearly demonstrate that NMO is clinically a different disease. Their observations would have met the same fate as Devick's had not Van der Lenen described the antibody AKP4-IgG in 2004. And I consider it my good fortune to have worked with them both at the Mayo Clinic in 2006, 2007. That's very young me, and that's Professor Weinshenker, and that's Dr. Lennon. That's my good friend, Dr. Marcello. Now, a marker for MS was much sought after. And in fact, MOG-IgG was equated to MS by Leber, Lennington, and Lassman. Unfortunately, these tests, their detection of MOG-IgG was using Western blots and ELISAs, which were fairly non-specific and was seen in other conditions and controls too. And it fell soon out of favor. Until in 2007, when Kevin O'Connor at Yale, using radioimmunoassay, demonstrated that ADEM patients, a proportion of ADEM patients, had MOG-IgG and had an antibody against MOG. And of course, they did not have the clinical phenotype of MS. He also understood that a proportion of patients who had the phenotype of NMO, but did not have the NMO antibodies, had MOG. And since then, we have, having found a clear marker for the disease, we've been able to characterize it much better. So, MOG has returned from MS into not MS. Well, it's not surprising. If you think of diseases as fruits, then we have oranges and lemons, AKP4 and MOG, and MS to me is a fruit platter. Clearly, the biggest fruit is going to be the prototype, typical relapsing MS. But there are going to be many, many small berries associated with antibody X, Y, and Z. One example would be GFAP-associated demyelination. If so, what proportion of seronegative NMO is MOG antibody? And this is my young fellow, Shahid, a few years ago. She's from Sudan, actually. She's now a neurology consultant in the UK. We did this work presented at ECTRIMS and published later. And we came to the conclusion that, if it is typical NMOSD, if it satisfies the criteria for NMOSD and their antibody, but it's negative, seronegative NMOSD, then about 42% are MOG. And if it is not MS, if it is not typical NMOSD by criteria, but it's demyelinating, in that category, about 20% were MOG positive. So, and this data has been studied in a different group, and their answer is 28% of AQP4 negative NMOSD is MOGAD. So what is MOG? Well, MOG is a protein expressed only in the central nervous system. In the CNS, we have the neuron, the axon, the astrocyte and AQP4. We have oligodendrocyte and the myelin. And MOG is expressed on the myelin sheath. What does MOG do? Well, we know AQP4 is a water channel. What does MOG do? Well, the short answer is we don't know. Perhaps it has a function in myelin integrity and in cell-to-cell communication and cell surface interactions. It's a really low proportion of total myelin proteins, 0.05%. But why so antigenic? Well, we do not know. How does the MOG disease develop? The most common question we get in MS clinics is, why did I get this, doctor? And we have standard answers. I always start off by saying, we don't know, but there are several possibilities. Same applies to MOG. For some unknown reason, the body decides, our immune system decides to produce antibodies targeting MOG. Produced peripherally, the B cells access the central nervous system, target the oligodendrocyte and the MOG protein and destroy it. The role of complement-mediated destruction is far lower in MOGAD compared to AQP4 NMOSD, where the target is the astrocyte and the aquaporin 4 protein, and the intense inflammation that ensues leads to significant axonal damage. It is really bystander damage that leads to the severity of the relapses and relapse-related disability in AQP4 NMOSD. In actual histopathological studies, as in this study from Anand Tripp and colleagues from London, this is the sample from. This is where the sample is from. That is a normal tissue. This row here, and this is the area from which the sample has been taken. Focus on myelin. This is normal. This is abnormal. This intense myelin loss, and you can see this is the astrocytes, and there is not much loss of astrocytes. Of course, there is some axonal loss. There is significant inflammation, particularly macrophages. What is the course, both clinical and serological, of MOGAD? So immune system produces antibodies. It is going in, causing damage. What happens long term? Well, let's first talk about the antibodies. We know from AQP4 NMOSD studies where the antibody persists for a very long time. Somehow the body is unable to clear, as in many autoimmune diseases, these antibody-producing clones of cells hiding somewhere in the nervous system or in the systemic systems. So once it's present, it remains with occasional flares during relapses. This is only one patient, but this is the trend we see. In fact, I had a patient who developed a leukemia following azathioprine for many years, and we did a bone marrow transplant. Even after bone marrow transplant, her AQP4 antibodies remained. Compare this to MOG. This is a study from Canada, Brenda Banwell and Patrick Waters. This is a cohort of children who were all MOG antibody positive to begin with. So 100% of them positive on day one. And as time goes on the x-axis, you can see the number of patients who become seronegative. And by 4 years, 60% become seronegative, which is unusual from an NMO perspective, AKP4 NMO perspective. And what happens to clinical relapses? This is the cohort from Mayo Clinic, and there are 3 groups of patients here, as you see in 3 different colors. The orange group is patients, all these patients had more than 1 blood sample, testing for MOG. Now, patients who were seropositive on both occasions, patients who were seronegative all throughout, ADEM had no antibodies, and the top group is those who had the first sample was positive and subsequently negative. And this is the risk of, this is the time, and this is the risk of probability of remaining without a relapse. And you can see that the patients who were consistently MOG positive had relapses. Those who were transiently positive, where the antibody disappeared, did not relapse. And the patients who never had the antibody in the first place had a medium chance of relapse. They probably have another antibody, as I alluded to earlier. What are the clinical correlates of a MOG antibody-induced demyelination? Well, the first thing to say is that there is some age factor here. Children tend to have an ADEM-like phenotype, while adults tend to have a more opticospinal phenotype of optic neuritis, myelitis, or combinations. How does the MRI look in MOG and AKP4 NMOSD compared to MS? And I must say there is no way of distinguishing, in my opinion, between MOG and AKP4 on scans that easily. There is no single marker. There are some exceptions. This is typical MS: periventricular lesions, Dawson's fingers, subcortical U fibers, cortical plaques, central vein sign, and the peripheral plaques in the spinal cord. These 2 are MS. The bottom 2 are MS, while the top is MOG. You can see they don't look quite like MS. Fluffy lesions, almost horizontal lesions. This is MS. This is the longish lesions in MOG. Here again, these are all MOG lesions. You can see atypical demyelination scattered, and some of them could be conceived as MS. For example, that spot and that spot. But overall, the picture doesn't look typical for MS. This was a paper we published in 2018. Again, Shahid's work. This is a case series. We started seeing patients who were MOG antibody positive and had seizures. Or other way around, we had a collection of patients who over the years had seizures and white matter lesions, and we did not know what caused it. When we tested them, we found them to be MOG positive. And we had 5 of these. Ogawa and colleagues soon enough published only cortical lesions. You can see this cortical swelling, and it's now been renamed as flames. Flare hyperintense lesions in anti-MOG associated encephalitis with seizures. It's a catchy name, but it is not unilateral always. But this particular case is, again, my case from last couple of years ago, a young child with a flare hyperintense and a diffusion positive. It can be bilateral, as in this case, bilateral cortical lesions. So these atypical things, which we often did not have a name before, we used to wonder what these cases were. A proportion of those have MOG antibodies. There are other presentations, ADEM-like lesions, cerebellar lesions, flames. And then this is again my case. It's looked like leukodystrophy-like lesions. So if you have a steroid responsive leukodystrophy-like presentation, nowadays think of MOG. Optic neuritis, you can see that around the optic nerve, there's some optic nerve inflammation and significant eye pain. This is the spinal cord imaging. This is MOG, that's aquaporin, that is MS, long lesion. And Dubé et al. Have described this H kind of figure in MOG. Central cord demyelination central cord inflammation in AKP4, often destructive, and peripheral lesions in MS. This is the case we published in NICP a while back, and this is a 50-year-old man. He had a pre-morbid MRI scan done for migraines, I think. And then he developed this predominant posterior parietal and occipital lesion with with the significant, apologies, let me just brighten the screen up, significant damage causing aphasia and seizures. And with time, you can see that he's developed a significant atrophy. This is the same patient. You can see that there is the valerian degeneration going all the way down, and there is significant dilatation of the ventricles. So what I intend to say is that though MOG was initially thought to be fully remyelinating with better prognosis, there are many patients who are left behind blind and can have significant damage from initial or subsequent events. So putting that all together, what are the differences between AQP4, MOG, and relapsing MS? I must say, nothing except the antibody is specific to AQP4 and MOG. It's a circuitous argument, it is a self-fulfilling prophecies, but that is how we are defining illnesses now. We use the antibody. I'm going to focus on MOG, but you can look on both sides. Prevalence, MOG is as common or more compared to AQP4 NMOSD and far less than relapsing MS. It is male and female have equal predominance. All races are affected. Young people are more affected. Coexisting autoimmune illnesses is less common. Viral prodromes are more common. Systemic involvement is not that commonly known. Perhaps there are reports now, but really you don't expect it. Bilateral optic neuritis is more common in MOG, particularly anterior with optic perineuritis. ADEM is common, cerebellar involvement is common. In children, ADEM is much common. In adults, it is optic neuritis more than TM. Seizures, encephalitis, aseptic meningitis are reported. Brain lesions are common in MOG, but obviously far less than typical MS. Deep gray involvement, long spinal cord lesions, very rarely MR negative myelitis. We don't know why. Perhaps it's a scanning. There are various issues. Maybe it is too subtle to pick up. Area postural lesions are rare, much less common than AQP4 NMOSD. Cerebellar lesions are quite common compared to AQP4 NMOSD. Isolated conus lesions, rarely leukodystrophy-like lesions. Conversion to seronegativity is common in MOG. Other antibodies are low. CSF bands can represent about 10%. Chance of relapse, it is not 100%, but probably it's much higher than 50%. Disability is much far less than AQP4 NMOSD, but some patients get disabled. As I mentioned, many rare presentations have been described. Whether these are associations or truly linked, we don't know. Does the antibody really cause all these things? Cranial neuropathies, chronism, we know these things. Sensory polyradiculopathy and central peripheral demyelinations. It's hard to explain these. Maybe it is coexisting. And of course, we know that many cases with NMDA antibodies and encephalitis can have coexisting MOG. How do we treat this disease? Well, in any case of demyelination, I always think, could this be MOG AQP4 disease? Because their prognosis is probably worse than typical relapsing MS following that particular attack. And what can I do to reduce disability? I sent off antibodies if I think this is not MS, and I treat well with high-dose steroids and a steroid unresponsive plasma exchange. And if indeed the antibodies come back as negative, then I taper the steroids off within a few weeks. But if they're positive, then I continue the antibodies long-term. How do we treat this condition long-term? The rationale that we use for treating AQP4 NMOSD, does it really apply to MOGAD? Well, you can see that the rationale that we use there is AQP4 is relapsing and lifelong illness, and it's not monophasic. But MOGAD may be monophasic, and it can remit. It is possible these patients have turned seronegative permanently. Even the low level of antibody may not cause the disease. Attacks have a good chance of being milder. And the risk of disability is overall lower, but though some patients can have it. So these things are going to factor in. We can't treat every patient with MOGAD on day one with long-term immunosuppression. So one has to be really cautious about that. We also know that the risk of relapse is highest in the first 3 months, as you saw from the previous Kaplan-Meier curves. In the first six months, you can see that the number of patients who relapse is quickly increasing. But if we put them on steroids, it is not as much. So based on these extrapolations, in UK, we drew up a guideline a couple of years ago. And this is what we do. Okay. And this is what I currently follow at present. MOGAD, antibody positive and typical syndrome, steroids for 6 months. Antibody, we retest the antibody. If it is negative, we taper it off. If it is positive and there are enough reasons to continue it, the steroids are tolerated well, we continue it. Repeat at 12 months. Negative, we taper off. Positive, that is at 12 months, the antibody remains positive and the patient has had a relapse beyond 3 months, then you have a chat with the patient and say, the risk of this happening again, the antibody is still there, then we continue. If it is no, then we probably want to try without it, because some patients do not relapse even though they have the antibodies, but the chance is high. And we always need to have that one-to-one discussion with individual patients. So if you're going to use a relapse prevention treatment, which one shall we use? Well, first of all, do these drugs work? Well, we know from work from Romain Marinier from France and other studies that in immunosuppressants, conventional drugs, azathioprine, methotrexate, midazolam, rituximab, they work. Patients without treatment will have relapses. So drugs work. And they did a study comparing the various drugs. This is a retrospective study. It is very difficult to match, but they found that the most common drug used was these three, azathioprine, mycophenolate, rituximab, and they reduced the relapse rates from somewhere between 1 before and 0.4 afterwards. 1 and 0.4 for azathioprine, 1.2 to 0.23 pre and post treatment relapse rates, and rituximab surprisingly only as good as azathioprine. The other drugs, we didn't have enough information. You can see this is 1.13 MSDMD to 0.49. So hey, the largest study on any drug in MOG is what Dan and I did last year. It's an international study. We asked lots of people across the world, do you have do you have MOGAD? Okay, Eric, start again. Hello, Eric.
Go ahead.
All right, so we're starting all over again on this slide.
Correct.
Okay, in 3, 2, 1.
The largest study on any drug in MOGAD is what Daniel Wittem did last year. So Dan and I asked a lot of people across the world if they had patients with MOGAD whom they treated with rituximab. And we found 121 patients. It is a lot of work. And this was our conclusions. If you take these patients, and I think we analyzed 103, I think, take these patients, okay, they're all relapsing patients, and you give them rituximab, if you take all of them, oops, as time goes on, at 12 months, so only 60% are relapse-free. And if you divide that up into people for whom rituximab was used as first-line drug, because they were not on nothing else other than steroids before, they do much better. At 12 months, 80% remained relapse-free. While if they had failed another drug, then only 40% are relapse-free. Now, those of you who have treated enough AQP4 NMOSD might be surprised at this, because for AQP4 NMOSD, B-cell depletion is wonderful. As you saw from the recent inebilizumab study, 80%, 90% patients remain in remission on rituximab or inebilizumab. Compare that to this. All those patients in the trials have tried other medications too. So there is something different here in our opinion. And it's interesting that even when the B cell counts were suppressed and it was zero, less than 1%, patients still had relapses. So there is more to MOGAD than B cell mediated antibody production. Some other factors, maybe T cell mediated mechanisms, are playing an equally important role, though there is no evidence for me to support that. Just a hypothesis. We also went on to ask, because all these medications are being used now, but really people who have seen a few patients have burnt their fingers with some mistakes are naturally choose certain drugs as their favorite. So we decided to cross-sectional survey people who have experienced this across the world. And again, there are about 60 authors on this paper. Again, a lot of work, Dan's work. And the question we asked many questions, and one of the important questions was this: what is the question is the popularity of individual steroid sparing maintenance therapies for as first, second, and third line treatments for a 38-year-old man with relapsing MOGAD. So which drug would you choose as a first line for relapsing MOGAD? And the first choice was the blue is azathioprine, and second was mycophenolate, and third was rituximab. Then we start, if the first line fails, which one do you choose? And most people chose rituximab. But you can see there are all the other drugs. IVIG, for example, is a good choice. Mycophenolate is a good choice there. So, and there is data such as that IVIG might be a good drug. And we also asked the question, if you think MS drugs may benefit in MOG, and we have nothing to say it won't benefit, other than the fact that MOGAD may be a primarily antibody-mediated disease. And the answer may have been somewhat obvious. It was ocrelizumab. But there are people who suggest teriflunomide, Tecfidera, all the usual suspects. So let me summarize now. MOGAD and NMOSD have many similarities, but are distinct diseases from MS. Suspect AKP4 and MOG disease in isolated optic neuritis, myelitis, ADEM, and variants. When scans look demyelinating, but not like MS. Atypical autoimmune encephalitis, for example, like NMDR encephalitis, or if there are additional lesions that doesn't quite fit the encephalitis, think about MOG. And unexplained, predominantly CNS white matter disease. Many of you might be following many cases over the years. We don't know what it is. Maybe it's MS. We're not quite sure. Test for MOG. If scans and clinical features are typical for MS, please do not test, because there's a risk of false positivity, which will skew everything. So perhaps not. It is often difficult to clinically or radiologically distinguish AKP4 NMOSD or MOGAD from MS or other demyelination at onset. So treat all the index events well while you wait for the antibody to return. I'm not saying this is for every MS patient with the first relapse. Somebody's optic neuritis, you do the scans, it's typical MS, move on if this is MS. But the scans are normal. It is atypical lesions. CSF bands are negative. Think about these two conditions. While recovery is good, residual disability does occur. And more than 50% of MOG seem to relapse. The best treatments for MOG, we don't know. There are many options. And perhaps with time, we'll understand more. And I suppose it will take time and probably much quicker to have a randomized controlled trials in MOGAD, because there is still significant ambivalence regards and equipoise regards the efficacy of medications. I want to thank the Cleveland Clinic MS term, who have welcomed me and has helped me develop our service. And of course, my previous lovely UK NMO SD team in Oxford and Liverpool, which I led. And of course, my own home, in UK, the Walton Center in Liverpool. Thank you all very much for this opportunity again. It's great being in the UAE, and I look forward to collaborating with all of you in various projects. Thank you very much.